In our process, we're including local health departments wherever possible in our outreach and ongoing collaboration and coordination efforts. Doing this added a step and some time in our process, but we thought it was really important that there was some level of buy-in and coordination with the local health departments because they had the mandate and the charge around the outbreak, and therefore we're officially leading much of the local COVID response. But our funding is going directly to the community-based organizations because it was also very important that we created a process where there were limited barriers to getting the funding, where the funding could be provided quickly, and where there was built-in flexibility and recognition that the CBOs are the experts of their own communities. And we wanted to support the creative activities and messaging that they identified as what was needed. Once the CBOs are funded, our team hosts kickoff meetings to bring the CBOs and the health departments back together for sharing, identifying any local collaboration opportunities, and or just to make sure everyone knows who's working in the space. And to add another layer in here, we are also in regular partnership with several state agencies to make sure that we can leverage and coordinate when other opportunities arise. Now, we designed Together Toward Health to be more than an initiative that is taking in funding to put out funding. And instead, we're providing additional coordination and support for the work and for the CBOs. We're now in a position to begin building out opportunities for the organizations to share and learn within and across geographic areas around population groups that they serve and also around specific topic areas. So we'll be creating and hosting a set of learning circles to facilitate this. We're also in the process of putting together a set of professional development and capacity building strategies so that the CBOs and their teams can add to their skill sets if they desire. So before I hand this over to Veronica, I just want to share that this pandemic has made clear the ongoing need for strong relationships with community organizations for so many aspects of public health. And we see Together Toward Health as supporting not only the immediate COVID needs, but also helping to lay the foundation for a strong community public health platform to support resilient communities into the future. And with that, I want to hand it over to Veronica.
Thank you, Susan. Hi, everyone. Good morning. My name is Veronica Garibay with Leadership Council for Justice and Accountability. We work in two critical regions of California, the San Joaquin Valley and the East Coachella Valley. The work that I will talk about today, thanks to the partnership outlined by Sue just now, we'll focus on our work in Fresno County. So if you're familiar with California, we're right smack in the middle of the state. I'll start by saying that I think we all knew, we're an environmental justice organization working directly with communities for several years. And we all knew that when with the onset of COVID, we knew which communities were going to be most vulnerable, and we knew which communities were going to bear disproportionate impact. Decades of neglect, underinvestment, exclusion from decision-making was going to put communities, and in particular Black and Latino communities, in sort of very vulnerable positions. And in the region that we work in, the region that I live in, our public health infrastructure is really poor. And so we knew that there's a lot of work to be done. And early on, that there were a lot of lessons learned. There was also an issue with decision makers not willing to then and even now really respond to the acute crisis that communities are still facing, despite urgent pleas from community residents to partner with them, to work directly with community-based organizations and residents throughout the region to make sure that we were saving lives. We primarily are working with the farm worker populations and population that work in food processing in particular. And as we've all heard across the country and in our state, that workforce was particularly hit in very significant ways. And so we, when the vaccine, I'll talk about our work to ensure equitable access to the vaccine. There were a lot of lessons learned from between March and December, and testing and how that went, and in particular, what the impacts were to rural communities. So the San Joaquin Valley is sort of the agricultural basket of the world, and there are some, in the San Joaquin Valley includes the fifth largest city in California, the city of Fresno. And while there were efforts to locate and establish mass vaccination sites in the city of Fresno, that did very little to address access by residents living in rural areas and more isolated communities throughout the region. And the issue, there are other issues. There's transportation to a site. There was access to information and correct information about the vaccine. Broadband access is real. The digital divide is real in rural communities, and not being able to navigate an appointment system or database, language capacities, sites, language capacity on site and language capacity of the tools themselves for people to access a vaccine. So what we did is we partnered with community residents and with funding support from the Together Towards Health initiative. We're able to put together a program that really led with equity in mind and led in partnership with community residents, recognizing that the way out of this is by sort of really building and strengthening and leveraging the trust and foundation built in communities and across communities that really help get the word out. So next slide. I'll start by sharing that, what guided our work in making sure that people have access to the vaccine was meeting people where they are. We first had to eliminate barriers. What are the barriers I just talked about to accessing a vaccine? Either geographic proximity to a site, access to information, access to broadband to even establish an appointment, knowing how to navigate the technology to do an appointment. Everything was in English early on, which was really difficult for monolingual Spanish speakers, which is the primary population that we work with. And so we built on our programs that we've done around, we've nonpartisan electoral organizing, get out the vote efforts, just organizing, back to the basics, door to door. So we started in a community, in a small rural community, which is about 45 minutes from the city of Fresno. In terms of getting there, is partnered with Fresno County Public Health, St. Agnes Medical Center, a medical provider in our region, and the Fresno local university, Fresno State Health and Human Services Program has a health mobile unit to establish and start hosting mobile vaccine clinics in rural areas. To get at registration and appointments, our team went door to door. As you can see here, my colleague Grecia, we knocking on doors to get people registered, share information for a vaccine clinic that was going to happen in their own community a couple of days later. Next slide. We also sort of built on what works in communities, and in other areas we flyered and canvassed neighborhoods to let them know that we were going to be in their community on a Saturday afternoon or Sunday to do on-site registration for a mobile clinic that would happen in their community a couple days later. A lot of us grew up sort of interpreting for our parents and answering questions and helping fill out forms. We see this same model playing out as farm workers, especially, and elderly and our seniors are trying to get an appointment, relying on family members to help fill out these forms and help answer questions related to their health. And, I've definitely experienced it, and I know many of us have experienced doing this. And so we built on, values and relationships that already exist in communities to make sure that people were registering for a vaccine. Next slide. This is again, going door to door, sharing information about the clinic, sharing information about the vaccine, which vaccine was going to be offered, what the difference was between that vaccine and others. And, there is a lot of information, and there's also a lot of misinformation going around through social media. And that may not always be right. So we spent a lot of time at the door trying to make sure that residents were aware and comfortable and able to access a vaccine in their own communities. Next slide. Can we go to the next slide? And then, this is a really important, another component. The Together Towards Health initiative didn't just fund Leadership Council and our work, they also supported the work of grassroots organizations, in this case, Community United in Lanier, which is an unincorporated association, a grassroots group of strong community leaders who have been working in their neighborhood and in their communities for years. This group of leaders has been leading 3 monthly food distributions in their community, organizing to make sure County Board of Supervisors were responding to their needs. And we were able to support their work and making sure that they too had access to funding for their time and resources to facilitate and both access to vaccine, but also share information about how to prevent further spread of COVID-19 in areas where we work. Next slide. Other, issues that are really important for us is, this was one of the mobile clinics. These are outside, like the fact that, and we're working in communities that don't have safe drinking water, don't have wastewater systems, don't have community centers, don't have parking lots, don't have, we have to get creative in figuring out how to make sure electricity gets to computers for registration and appointments and et cetera. But that's not a reason to not do mobile vaccine clinics in communities. And in this community in particular, we set up vaccination, observation, registration, all on site, and really went smoothly. We in this community, we were able to do 380 vaccines in less than 3 hours, all focused on the farm worker population. And this was a community where we had gone a couple of days ahead, a couple of days prior to the date of the clinic, to do door-to-door and on-site registration. So by the time people came for their appointment, they were registered, they were ready to go. It was a very smooth process. And that was a result of sort of really direct communication between the CBOs, us, community residents, the local public health department, the medical provider, and the nurses, to make sure that we were all on the same page so that these events go smoothly. Next slide. And I'll end with this. This was the night after our first clinic, our mobile vaccine clinic, and it was a lot. We learned a lot. It was a lot of work, a lot of door knocking, answering questions, helping folks navigate the process. And one thing that stuck with me as we were cleaning up and heading out for the day, one of the community leaders came up to me and she said, we did something good today. And I think that was a reminder of how dark this year has been and how there's been so much loss in our communities and so much pain, and really a lot of just darkness. And we know that unnecessary lives were lost to beautiful souls that many of us won't ever see again, but their memories will stay with us. And it was just a reminder to sort of, for all of us as we're doing this work and making sure that people have equitable access to the vaccine, it's a reminder that, this is good, and that we should sit in that moment and take in that joy that is bringing hope to communities, especially communities that would otherwise not have access to a vaccine, would it not, if it weren't for direct partnerships with local health departments and community-based organizations. And I'll stop there. Thank you.
Thank you so much, Denise and Veronica. That was fantastic. I really, like what you just said. We've done something good today. And so I hope everyone on the call, remembers that, because you're all working every day to fight this deadly virus. And so everyone's doing something good each day. So thank you so much. We'll have time for some questions and answers that are coming in just a few minutes. So I now like to turn to panel number 2. And I'm pleased to present and to welcome our presenters for our second panel for today's webinar. This panel will focus on community health workers improving vaccination uptake. And we'll start with an overview of the essential role of community health workers from Denise Smith, who is the founding executive director of the National Association of Community Health Workers. And then we will learn about a local example from Fiorella Horna. She is the COVID-19 Latina Outreach Project Director with El Centro Hispano in North Carolina. So Denise, we will turn it to you, and then we will hear from Fiorella.
Thank you so much, and good afternoon, everyone. It's an honor to be here and to share the panel with Fiorella. I'll just be before you for a few minutes. I want to take a moment, if you would, just to acknowledge and reflect on community health workers, our promotoras, our community health representatives across tribal nations, and indeed CHWs in at least 50 titles all over the globe, who have been pressing into this pandemic in unprecedented ways. Community health workers have been designing, developing, distributing materials, creating strategies that are anchored in and respectful of community health beliefs and cultural concerns and preferences. We've been coordinating and administering food distribution, addressing housing needs, financial needs, helping people to enroll in benefits that came through the CARES Act and additional stimulus, screening for mental health services, and helping people directly navigate and receive those services. We've been helping our elders to navigate technology, literacy, language, enrollment, and transportation barriers to ensure access to testing, and to the vaccine, as well as to well child appointments and other immunizations. We've been coordinating mobile testing and vaccination sites, tabling and helping people to register, collecting data, monitoring systems, and engaging in recruitment and support for those who are homebound, those who are houseless, those who are in transient communities. And I want to celebrate my peers, my colleagues, and my elders in this work, those that we have lost over this past year, as well as those who have created innovations that were it not for panels like this, we would not hear about them. So we celebrate your work and service. Next slide, please. Thank you so much. I wish I could say to you that during the early months of the pandemic, CHWs were integrated into systems and services and task forces around the country at the federal, state, and local level. But it was not the case. In the early months of the pandemic, our members and partners from across the country told us that they were being laid off and furloughed, that their doors were shutting down, and that their employers often did not understand their trusting relationships with community and the ways in which they should be centered for pandemic response. NACHWA launched a national campaign. We're a very small organization, so we could not have done it without our partners from across the country to amplify 3 critical points that I'll make here. Number 1, on March 19th, 2020, the U.S. Department of Homeland Security issued guidance to states, tribes, and territories classifying community health workers as essential critical infrastructure workers and recommended that they be paid to respond to COVID-19. There were very few states that adopted this guidance. And so while we were strengthening innovations in clinical response, standing up telehealth, addressing the needs of our public health infrastructure, our CHWs were anxious, frustrated, and concerned. One says, I've had difficulty getting a response from the emergency response team in my community. I've called, I've emailed the city, I've joined their Facebook groups, I've answered their questionnaires. It's very frustrating. A lot of that early work was extractive, asking CHWs to share their stories, their struggles, their innovations, but CHWs were not centered as leaders to innovate, to design, and to center community needs. The second point I'll make here is that CHW networks, associations, and coalitions, no doubt like the stories that you'll hear from Fiorella, these are essential infrastructure organizations at the hyper community level, and they needed funding to scale their innovations. Our associations, our coalitions, and our networks were places where CHWs congregate across sector and across experience. And we were ready to help with recruitment, with hiring, with training, and with supervision. But often those funding streams did not come our way. So it is important to recognize our leadership capacity as an individual CHW, but also in our networks, coalitions, and associations. Next slide, please. NACHWA was grateful in those early months to be able to partner with the CDC. We developed an English and Spanish webinars to help articulate our roles to public and private institutions with the ADA and ASTHO and many others. And I just want to acknowledge here that we could not do this without authentic partners and allies. So we just want to offer these and other resources. When you receive the webinar, all of these are hyperlinked so that you can click on those videos, you can click on those trainings, you can read those blogs, and you can learn more about the work of these associations, these alliances, these coalitions, and these webcasts. Next slide, please. As I begin to close, I just want to point out a couple of things. It is essential that public and private institutions, that employers, from hospitals to health plans to federally qualified health centers, learn from the work that is coming out of CHW expertise. And so NACHWA worked alongside the Community-Based Workforce Alliance. We worked with partners like Visión y Compromiso and El Sol in California, LaShawn in Louisiana, many other CHW or Promotora or CHR organizations to help provide ways to go from visualizing and sort of theoretical frameworks to really operationalizing equitable recruitment, hiring, and integration of CHW expertise during this time. We offered a checklist primarily for administrators, managers, and clinicians who may already have CHWs on their staff, but those staff members were working in discrete roles and they didn't really understand how they could adapt those roles and work with those CHWs to support equitable vaccine distribution, for example. So these tools and resources are made available to you, and they come from best practice and recommendations from the workforce. Next slide, please. As I close, I just want to say that policy is essential for sustainability. The big question here is whether this moment, this pandemic moment, is going to become a movement that centers racial equity, that invests in our hyper local, culturally relevant and trusted community-based organizations, and elevates the sustainability for our CHW and our Promotora in our CHR workforce. So in February 2021, after a year's worth of national town hall calls and polls and lots of meetings with our members and partners, we launched this national CHW policy platform. I urge employers to consider this language as you intend to scale up through recent funding, additional CHWs into your operational budgets, ways in which you can do that equitably, understanding their lived experience as well as their training and certification, ways that you can ensure that they have a living wage, that they have access to PPE, to self-care, and to the protections and benefits that this workforce needs. CHWs are a precarious workforce. We're predominantly female. We're predominantly people of color. We are some of the lowest paid throughout the public health ecosystem. And so again, the shift from a moment to a movement is sustainability, where we are creating career paths, where we are acknowledging and centering expertise, where we're funding deep into our communities so that we can rebuild and recover truly in an equitable way, and be ready not only through this through this pandemic recovery, but for future pandemics to come. Next slide, please. Well, thank you so much for your time with me. I'm excited to hear Fiorella Horna's presentation, so I just want to welcome my colleague to the panel.
Thank you, Denise. I just want to say yes, 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 and echo everything that both Denise and Veronica has said. They have really described the very things that we faced as we were going out and doing the work. And so a lot of the things that Veronica mentioned were strategies and approaches that we also used. And a lot of the call to action things that Denise mentioned were part of our advocacy efforts. Thank you for sharing a lot of those experiences. Well, El Centro Hispano is a nonprofit organization that's dedicated to strengthening the community, building bridges, and advocating for equity and inclusion for Hispanic Latinos in the Triangle area of North Carolina. Our priority areas focus on education, economic development, health, and well-being. So community health workers were a part of our work before the pandemic even was hitting, right? Since we believe that the best way to do work is to engage community members in that work. So next slide. As the pandemic unfolded, our community health department ended up really revving up and having to take the lead in setting strategy, in mobilizing partners, in speaking to advocates, and in getting the community health workers involved. We had to answer the call to action, and it was actual call. It was like Friday, March 13th, the governor said, let us stay in order is now in place. Please, everybody go home type of thing. On Saturday morning, our president CEO's cell phone was, just going off with people asking, what does this mean? Do I not have a job? Will I ever go back to a job? I didn't get my paycheck yet. I don't have food to stay in place, all of these type of things. And when we got the call, it was first like one family, 2, 3, 4, then 5 families later, she just sent a internal text to all of the staff. We have Workplace, if you guys have used that to communicate with our staff. And so she's like, hey guys, I'm hearing some families need some help. Anybody willing to pull some things from your pantry and sort of put some boxes together to help these families? And so the staff replied by opening pantries, opening their pocketbooks, and we put together food and we served the families over the weekend. No problem. Monday morning, bam, right? The phones are going off the hook. What's going on? And so we have a community support department that is the intake of the calls. They're the ones who receive the social media messages, the texts, the emails. And so they're like, you guys, something's happening. So when we know something's going on in the community, it's because community support is seeing a heightened awareness of things. And so they flagged us. People are concerned about the pandemic. They don't know, what is this virus? What's happening with my job? What do I do with food? What does this mean to my child? What happens if I get sick? And so we took it on to say, okay, let us go back to our partners. Let's go to the health departments, right? This is a public health issue. Let's go there. Let's go to our food security partners. And we actually had a meeting that morning with our food security partners. And we're like, perfect. We'll tell them what's going on. It's like, you guys, we've been getting all these calls. What's going on? We have to stay in order. Who can help? Crickets. Right? Oh my gosh, our traditional partners who had food security were dealing themselves, right, with having to close doors. Volunteers weren't around anymore. They didn't know if they were going to have a secure flow of food. So all of a sudden, El Centro Hispano, who had never been a food bank or done food security or foods distribution of any sort, found themselves saying, now we have to do food, right? Because we have a need that needs to be met. one of our partners called and said, look, Fiorella, we're only 2-3 people strong in our department. We have food. Can you take it? We're like, yeah, bring it. We'll put it together. We still have our staff in the offices. We'll get the boxes together. So there we go, putting the boxes together. And all of a sudden, my community health manager calls me and she's like, Fiorella, they dropped off food. We're like, yeah, well, get the boxes together. She goes, no, they dropped off food. She puts me on the FaceTime, shows me outside the door, 3 pallets of food. Like, what do we do with this? I was like, I guess we're setting up a store. And that's what we did. We ended up having people come through and pick up their food and go what they needed to do. I share this is because sometimes one of the things that our community organizations have to be is flexible, right? If we're going to be responsive to the community's needs, then we have to be flexible to meet that need. And it may not be part of what you're doing right there and then, but it's a need that you have to meet because no one else is around. Next slide. As we started doing all this work, we started speaking to other partners, trying to secure money to be able to pay, provide money for financial assistance, for rent assistance, for food security, those kind of things. And so one of our partners submitted a grant as a collaboration, and we were able to secure monies to host 40 community health workers. Now, we already had 10 that were engaged working as part of our Healthy Lifestyles initiative. I had done some work with the March of Dimes, and we had some other promotoras that we had already been involved with. So we brought those two together. We had 30, and then we recruited 10 more. All of these promotoras were then called to action for COVID education and outreach. Luckily, the CDC around that time had also been putting out trainings for community health workers around the pandemic, and we were able to get on just in time to get all of them trained by the CDC. We received training by our medical director at the state. Then we received training by our community health departments. So that was important for us because these community health workers represented the community, lived in the community, spoke the language of the community, understood the barriers, and were their neighbors. So immediately they started with first my family, then my neighbors, then my actual networks of my church, my business, my work, whatever else, and then out into the neighborhoods that I possibly was not aware of. And there's where we sent them 2 by 2. Next slide. The role of the community health workers for us became finding, teaching, connecting. They know that. When we say, what do you need to do? Find, teach, connect. What does the finding look like? Next slide. The role of going out into shopping centers, homes, neighborhoods, work sites, calling people over the phone, messaging people over their Facebook accounts to let them know, are you aware about this pandemic? Do you know what to do? Do you know your 3 M's? And they shared messages and actually CDC approved materials. And we even developed materials that were more culturally appropriate and in Spanish, as Veronica mentioned. Having materials in Spanish was one of the difficult things, right? Any communication in Spanish was hard. And so they ended up using that material to go out to people and let them know. Next slide. Now, I should say that they're still doing this, so it's not like it's done, right? So teaching, they went into businesses. They worked with an initiative called Count on Me, which provided some checklists for businesses of what am I doing to stay safe? So we went into Latino businesses, did the checklist, helped them think through what they needed to do, provided resources, did training for their staff, left them PPE, sanitation bottles, things like that. And then they had a little poster they can put in saying that they were united against the virus. We started a campaign that's called NC Unida contra el Virus, or NC United Against the Virus. And so any poster that was there showed that that business was committed to keeping people safe. They also went to churches and literally were given time on their on Sundays to get up at the pulpit and speak about ways that they could do what they could do to keep their families safe. And they submitted, they gave PPE on site. We also hired some of our community health workers as artisans. They actually were sewing cloth masks. So these cloth masks were given to church facilities. Construction was an area of concern for us because of the housing. The farm workers had just left. You guys remember, this is toward the end, right? This is that July, August, September. Farm workers in North Carolina were revving up, getting ready to go home. So we missed that opportunity to catch them when they were going back, but they're coming back in and we're ready for them coming back in. So our focus were on construction workers, making sure that they were staying safe and being able to identify where were the risks there. The risks were in the transporting back and front from work. And that's where we started then giving hangers for their cars that said, if there's more than 2 people in this car, you better have a mask, and with the instructions of what they needed to do, and drop PPE, did training for construction sites. Next slide, please. Here is connecting. The connecting part is a lot of like what Veronica was talking about earlier, right? Making sure people knew where to go, answering the questions, taking our mobile unit out there with some health screening and health education, being able to take testing with our mobile partners. We had a community health center, we had our health departments that were willing to go out there with testing. And today with vaccination, we do pop-up sites, we take mobile units, and we take mobile sites out there. We can either actually set up a site as well as support a site. Next slide, please. The promotoras were the first to go ahead and be an example. So they went and took their vaccine, and then they posed, and they would post it all around their Facebook and invited their friends to come get a vaccine. And when people had a question, they answered it. We opened up a vaccine line to be able to answer questions. Next slide. Here you see them in action. This is an actual support of a health department drive-through vaccination event. Next slide. Oh, and there was one more that shows when they've actually popped up. So they do logistics, everything from the beginning to the end. So these are our community health workers in action. This is after an event that they've done. They've now provided about 2,000 vaccines to Latinos in our community. And next slide. Thank you for your time. If you need more information or want to access resources, please visit our website. Thank you for this time.
Great. Thank you so much, Denise and Fiorella, both just excellent presentations and a wealth of information. So we have a number of questions that have been coming in. We certainly won't be able to get to all of them, but I would ask if we can get all of our panelists back on the screen here for our question and answer period. And we will go ahead and get started. While we're getting the panelists up, one of the first and early questions that came in was around a request regarding a funding opportunity, the national initiative to address COVID health disparities. We wanted to just make sure that folks know, yes, there is a funding opportunity out there from the federal government. There is a technical assistance webinar about that on March the 30th, and we will make sure a link gets put into the chat about that. We believe, from what we understand, it's that states and large cities are eligible, but certainly there's that expectation, again, that they have to work with community-based organizations and have robust partnerships. So certainly want to make sure that everyone is aware of that. Are we able to get all of our panelists up, or is it just me that I can't see everyone? Oh, I see everyone now. Great. Okay. So, all righty. A couple of questions around volunteers. As you all were doing your work, did you utilize volunteers, or were all of your folks that were engaged employees, if you will? One of Veronica or Fiorella might want to respond to that.
I'll just say really quickly, it was both paid staff and community volunteers, residents in the neighborhoods where we were doing mobile vaccine or are doing mobile vaccine clinics who wanted to help out.
Okay.
Same here, both.
Okay. And A question around payment. So who is paying for the community health worker programs? It sounded like certainly in one case, some of the resources came from Together for Health, but in other cases, do you want to respond to that?
For us, it was Together Towards Health funding, private philanthropic giving from other foundations that have supported our work on COVID response. And then finally, we are in the process, this took some time. We are an advocacy organization that questions and sometimes, advocates really strongly against some decisions that our decision makers take. So it took a while, but now are actually working with 2 counties in particular to be contracted by the county, utilizing resources that the counties are receiving to respond to COVID to pay for volunteers and staff doing this work. I think Fiorella noted this, and Denise did too. There is the state in California, there's also been a lot of work to make sure that as the state is dispersing funds and putting together health equity metrics and reopening guidance, that there are these requirements that you must work with community-based organizations and develop a targeted equitable investment plan to make sure that communities, residents in the most vulnerable census tracts, according to the tool that Susan talked about, are actually getting resources that they need. So that also helps speed up the process, but that's another avenue. I know somebody added that question in the chat about some of the money local governments are getting. Yes, they can use this money to partner with CBOs to do this work.
Mm-hmm.
Yeah, for us, the state health department and our county health departments provided funding. And we also partnered with an organization that we were already partnering with before, not related to the pandemic, but we collectively submitted a grant that was funded through CARES money, right? So that funding allowed monies to be funneled back into the organization and then sort of scale up with the number of community health workers we needed.
Great. So I think that there are questions also around training, and I believe Fiorella touched on this a little bit, but do you want to say a little bit about the training for your community health workers? Was it that there was a structured training, or how did you go about that, and particularly in sort of real time and with short deadlines?
So for us, we had already had training for our community health workers before the pandemic related to outreach, just being outreach and advocacy. Those were some trainings that we were already doing. However, when the pandemic hit, like he's mentioned, it was fortunate that the CDC Community Health Workers Initiative had training already. So we were able to kind of piggyback on that. But then, as you mentioned, the training still is happening. So we have allocated every Thursday afternoon from 3 to 4:30, it's dedicated for training. So we ended up having to do the NC Care 360 that in North Carolina is a way to bring together many partners around resources. So we had to train people around NC Care 360, contact tracing, right? Just how to do first aid CPR. In fact, today they're doing that because we've been doing several vaccination sites and we've had some people have adverse reactions, which was scary. So we're like, okay, what do we do while we're waiting, right? So everybody's getting trained on first aid CPR. So yes, we had some basic onboarding things that we just needed to make sure everybody had, HIPAA rules, privacy rules, but now we continue building upon them as they are working in the community.
I suspect that some of our national organizations like Denise, your organization, may have some suggestions and tools around training. So I certainly would invite folks to visit those websites. We have time maybe for just one more quick question, sort of rapid fire. And I want to pull Sue in. And one of the things you mentioned, Sue, was the Healthy Places Index in terms of an important tool. And so the piece around data, I heard things around technology challenges, but also the importance of data. And so there are questions about what data was collected during these events. How did you do it? And how did you overcome some of these technology challenges? And so I wonder if anyone would like to add a perspective around data to this conversation.
I mean, I will just say, thank you for the Lily added in the chat box a link for the Healthy Places Index. And so you can see that tool. And so we had the benefit of having that kind of resource to pull broader data. It's also what our local health departments are using for their own census tract information. But for the grantees that we're funding, there are data points that we're collecting when they do reports around number of people reached, number of people facilitated getting vaccines, and those types of elements. But I'll let others share in the field. I think, as Veronica was mentioning, if there's no electricity, and I think I saw images where they had tablets around their, that they're carrying. And so I'll let her respond to that.
Great. We have 1 minute, so just a quick rapid fire for us, Veronica.
Sure, I think Sue answered it. Just we are using tablets to collect data, do the registration. We worked with Fresno County, the county, the tool PrepMont, what they were using to collect data and do registration, to have a running list of who was coming, who's going, what issues there were, so medical providers would have access to that.
Great. Wow, well, just not quite enough time. There's just so much fantastic information and really a packed hour here. I want to thank Susan, Veronica, Denise, and Fiorella for your presentations, the sharing of this fantastic information, and the discussion that we've just had. You certainly shared pearls of wisdom and practical tips for the audience and colleagues in fighting this pandemic, and we want to thank you for all of that. We certainly heard about the importance of the integration and working together between CBOs and health departments, the importance of partnerships and bringing all the people together, and then how do you leverage those partnerships, the role of promotoras and the impact of programs, the key messages around find, teach, and connect, the wealth of knowledge that national organizations such as the National Association of Community Health Workers has, and important regional organizations like Public Health Institute, a number of different tools and resources that were highlighted, the importance of policy and a movement and putting in place what we need now, but what we need beyond now for all of these complex public health issues, and a real important message about you're doing something good. And so take the time to celebrate that and reflect on that as we roll up our sleeves and keep marching forward. So thank all of you for what you've shared with us today and for our audience participation. As we wrap just our call to action, we are still in a pandemic. We know that many more people are getting that vaccine. People are anxious to get out and return to normal, but it's still so important that we wear our mask, we watch our distance, we wash our hands. And if you haven't gotten a vaccine when it's your turn, we certainly encourage you to do that. We know that more funding is coming out to support community-based organization work. And so just continue to keep your eyes out for that to support the work that you're doing. We have our resource center, and we invite you to go to the resource center and see the materials and information that are there. And as I close, the last slide is, again, thank you for attending. We certainly will continue with these webinars in the future. There will be a polling question as you sign out, so we ask that you please take a moment to complete that poll. Your ideas are important for future webinars. Information that I saw in the chat, for example, around a rural issue. So thank you so much and have a great day.